everybody, and welcome to Tuesday Training. I hope you're having a fantastic week. As always,
we are live from Austin, Texas, right here at Insurance Syndicate headquarters. And man, we have a great show for you.
What is up? Drop in the comments. I think we're having some audio issues. I'm not sure you guys can hear me. Put it in the comments. Can you hear me? Because we seem to be having some audio issues here, I think. So, can you hear me? Boop, 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 boop. For some reason, drop it in the comments. Audio. Check, check, mic check. Seems like it's working. Please put it in the comments. Can you hear me? Say yes or no. Can you hear me? Yes, thank you. All right, perfect. Man, we got a good show today. Get excited. Really good show today. I'm super excited about some of the stuff that we're going to talk about. All Medicare related good stuff. You probably saw the post that I put up this morning. Not going to talk about it yet, but we'll jump into in a minute. Lots to talk about. But first and foremost, I want a big shout out to my guys over at DFY for helping make this show possible, man. Love that CRM. Love that team. As a matter of fact, they just rolled out a new update. I'm not sure if you've heard about it, but they added in a new update to DFY called Webby Chat. And Webby Chat is a fully automated webinar system where you can create pre-recorded webinars, but launch them like they're live, including a live chat feature where you can program timed messages that you want to appear in the chat. You can even create artificial intelligent audience viewers and make them ask questions in the chat to increase engagement. Super slick, super automated, all integrates right into DFY with your Facebook ad platform, all your automations, et cetera, et cetera. We are rolling it out now and super, super excited. So thanks to the guys over at DFY for bringing that to us. And man, do we have some news for you guys. Before I jump into that, though, I want to recap a little bit. I went out to Medicarians last week in Vegas. Absolutely amazing event. There was 4,200 registered agents showed up for Medicarians. 4,200. It was packed. Now, if you've never been to Medicarians, it is a little different event than some of the other events that are out there, right? Different than, say, 8% Nation, Medicare Con, 7-Figure Medicare Summit. It's a little different in the structure of how they do it, right? You go to some of these events and it's just one big general session, right? That they bring speaker after speaker. Maybe they have some side breakouts here and there in the mornings or something. But for the most part, everybody's in one room listening to the one speaker at the same time. Totally different at Medicarians. Dude, Medicarians, 4,200 people, like it's amazing. Huge expo hall, an absolutely magnificent expo hall. Some of these booths had to cost $30,000, $40,000, $50,000 easily that some of these vendors are putting together. So they have a monster expo hall, and then they probably had 20. I would say they probably had around 20 different rooms that they were running simultaneous classes in. So you had to look at the schedule and kind of figure out what you wanted to go to. Do I want to go talk about Part D trends? Do I want to go listen to conversations about disruptions in the Medicare Advantage space and why that might not necessarily mean an upswing for Medicare Supplement? All that kind of stuff. All kinds of information about ACA and Medicare trends, technology, plans, et cetera, et cetera. And as much as I enjoyed the event, there were a lot of sessions that had a little bit of an issue in that they didn't have a lot of information because we got some information recently. It's a lot of that I'm going to talk about. But at the time last week, we weren't really sure where we're headed. So a lot of the executives and people that were in some of these different sessions are like, look, we're speculating a little bit because, to be honest with you, and I'm glad that they were very honest, they're like, we really don't know exactly what's going to happen, right? We're still waiting. At that time, we were still waiting on CMS final rulings to come out. We were waiting on Medicare Advantage payment rates to come out. So everybody was like, we don't exactly know what's going to happen. But the biggest thing that I got, one of the biggest takeaways that helped me leave that event with a lot of confidence, was that every executive that I talked to, every high-level Medicare person that was on stage, while they would in one hand admit, we don't exactly know what's going to happen, they all backed it up with saying, but we're very bullish about the future of Medicare for us as independent agents, brokers, FMOs, NMOs, carriers, etc. So I appreciated their honesty. They're like, look, we don't know exactly what's going to happen because we're sitting in this weird place with these rules right now. We don't exactly know how the new administration is going to behave on them. And we have lawsuits that are going on as well that still haven't been done. So everything's kind of in this weird limbo mode. But we're very bullish about the future. And with a lot of the news that dropped today and last Friday, yeah, you should be very bullish about the future in the Medicare space because this is definitely looking bright. But all in all, dude, Medicare, there was an outstanding event. In addition to all the different classrooms, they had roundtables where you could sit and have like an open mastermind discussion about different topics. I sat in one with Victoria Cabrera talking about AI in your business. I sat in another one. I can't remember the gentleman's name. He was a high-level attorney that works in the lead generation area. And he talked about compliance and lead generation. So we all got to kick around ideas. What is compliant? What's not compliant when it comes to social media? This, that, the other. Tons of great information. They treat you like a absolute celebrity when you're out there. I mean, they feed you constantly at that event. Throw great parties. Like we got to see Flo Rida. I'm not like a huge Flo Rida fan, but it was still a cool event. There was probably 1,500 agents that stuck around to go to that final VIP party. But all in all, a great event, man. If you have never been to Medicarians, I would highly recommend you at least go once. It's interesting because the history of that event, it used to be called the Medicare Supplement Conference. And this was back when a gentleman named Jesse Sloan ran it. Was always a good event there. Was a little different. That event tended to be centered around the Medicare supplement world. But as our industry evolved, he started bringing in more and more conversations about Medicare Advantage. But his event was a little more just for the executives, right? Just for the higher level distributors, FMOs, carriers, except he had one day that was really dedicated to agents. And agents could come out that day, visit with vendors. They would see more topics that are kind of at field level. And then the other days were all big, high level topics on trends, where the industry is going, et cetera. A lot of that still kind of maintained, but there's a lot more information for field level now in these events. One of the best topics that I sat in and listened to that was really good field information was client retention strategies. Got to hear from Brock Emery and Kevin Brown on some of the things that they are doing to maintain a very high level of retention with their clients. Got to sit in on other conversations regarding cross-marketing, different strategies for maybe cross-marketing by selling off the scope of appointment or learning to bundle sales. So they've definitely expanded it there. And that really shows because you had 4,200 agents show up. So if you've never been to Medicarians, make it a point to go. While the tickets can be a little pricey, every year they also allow you to sign up for a hosted ticket, which means you get to get in the show for free. And I actually threw out some free tickets. A couple of people took advantage of them. So if you're looking to go next year, just keep your eyes peeled. You will likely have an opportunity to just cash in on a free ticket, cover your travel, and go have a blast at the event. So all in all, tons and tons of fun. Now, with that said, let's move on to some stuff. Let's just kick it off. Let's go with this article real quick, just right with a little bit of bad news. It's not terrible news. And this was the only article I could immediately find on it. It's out of, out of Time Magazine. But it says right here, as of April 7th, Medicare will not cover GLP-1 drugs for weight loss. Still going to cover them if you're diabetic. But if you're taking it for weight loss, Medicare ain't covering it, right? It says right here, the Centers for Medicare Medicaid Services recently announced, without explanation, I like how they throw that in there, that it would not proceed with a proposal initiated by Biden administration to cover weight loss drugs like Wegovy and Zepbound for its beneficiaries. Medicare and Medicaid recipients can be reimbursed for the medications that treat diabetes, but currently the anti-obesity versions of these drugs will not be covered. And man, why they have to say this without explanation? You don't, if you're not an idiot, you don't need any explanation because those drugs are expensive. And if all of a sudden we just start doling them out to everybody else and Medicare's covering them just because you can't put a fork down or whatever the situation is, that's going to be an issue. But nonetheless, yes, your GLP-1 drugs will not be covered for weight loss, diabetes only. And then the top of the hour, I got this one in today. I already posted this in the group. You guys may have already seen it, but this just in. Guess what? Medicare Advantage payment rates are going up again. I'm not surprised, but I am surprised a little bit, right? I was sitting here thinking about this yesterday. I'm like, it's like, what are they going to do? Like, because they have this new Doge committee that they've created that's cutting spending, cutting fraud, waste, and abuse. So it made me think, like, are they going to clean up so much money in original Medicare that they free up more money to give to Medicare Advantage plans and boost the payment rate like we're seeing? And then I was also thinking, well, but they're really trying to be conservative. Maybe they won't. Maybe they'll clean up some money, but they still want to keep that Medicare Advantage subsidy a little more nominal. But no, coming out with a 5.6% bump to Medicare Advantage payment rates for year 2026. That's a massive increase. That is an absolutely massive increase comparatively. And when I say comparatively, I'm talking about looking at the trends for all the payment rate changes that have been made over the years, right? I've talked about this a lot. I've studied it a lot. If you go back and you look at payment rates increases over the years, they started really in 2014. And I've actually taught a whole continuing education class on this before with NABIP. But if you go back to pre-2014, they weren't really doing much with it. But in 2014, they actually had a bill put forward that they were going to reduce the payment rates to Medicare Advantage plans. But then they said, no, they flipped it and they increased it. And they've been increasing the payment rate to Medicare Advantage plans ever since 2014. Every single year, hasn't missed a beat. Every year. They have not dialed it back whatsoever with any decrease. Some of the increases have been bigger than others, certainly. If you look at Trump's first term, he was actually one of the most modest in the 4 years. He kept it pretty nominal. I want to say I'm going a little bit my memory here. I think every increase that he made during this first term was under 3%. It's like 2.5, maybe 2.9%. Biden came in his term, and he actually set records in 2 consecutive years. If I'm again going by memory, I want to say it was about a 4.5% increase, like 4.42, which at that time was double the previous year. And then he followed up with an 8.5% increase, which is what caused that massive explosion in footprint in 2024 that we saw in 23 and 24, technically. So I was a little shocked to see it this big. I thought, if Trump's going to do it again, he's probably going to keep it in line with what he did before, maybe around 2 to 3%. But no, he comes out with 5%. And when you think about a 5% increase, when you're talking about billions of dollars, my understanding is this number equates to around a $25 billion increase to Medicare Advantage and private insurance plans. So with that, we're going to see some plan growth this year. We're going to see some plan growth. I don't see any other way around it. I'm kind of curious of how they're going to tackle the explosion. Is it just going to be a footprint explosion? Are we going to see a benefit explosion as well? More supplemental benefits again? Are they putting all those back on the table? Because the trend has been to pull back, and even our current administration, I believe, is pretty tight on the usage of supplemental benefits. So I'm really curious to see how the plans react to this. But if anything, if history has ever told us anything, 2 things are going to happen that I'll predict. One, we're going to see another giant footprint increase with a lot of the larger carriers, right? The guys that can definitely handle it and take advantage of it. We are also, I'm just going to guess, we're probably going to get a raise in commissions. Every year that we've ever had an increase in subsidy payment without fail, the FMV, the fair market value of Medicare Advantage commissions to independent brokers, goes up a little bit. Every year without fail that they do an increase, we get more money. So there's a possibility that we're going to get an increase as well. I mean, I would pretty much put all my ducats on it based on history, but you never know. They might say, no, all that money just goes to the MA plans. We're not changing how much they pay you. We'll see how that goes. And as we know, there is a lawsuit, there are lawsuits still going about that compensation rule they came up with a couple of years ago. It's been, judge put an injunction on it. that is technically still kind of floating out there on the table. It's not coming for 2026, and we'll go into the 2026 final rule here in a minute. But that could be something they look at in the future, right? And I was thinking with their really conservative ideas of what they're trying to do and saving money, I thought it wouldn't surprise me to maybe see them do an increase to MA plans, but possibly to reduce our commissions to put more money back in those MA plans pockets. Any of those could happen. So wouldn't completely surprise me if they turned around and said, yeah, no, we're not giving y'all an increase. We want all this money to stay in the MA plans pocket. But chances are we're going to see a little bump in commissions too. So there's not much really to say in this article. But it's, pretty basic. It says right here, the Center for Medicare and Medicaid Services finalized an increase of the average benchmark payments to Medicare Advantage plans by 5.06% on Monday. It is nearly a 3 percentage point increase over the advance notice proposed in the waiting days of the Biden administration. The previous final rule or previous payment rate that Biden threw up right before he left office was, I think, like 2.2 or somewhere in there. Is one of the lower ones that I've ever seen him put out. So they're kind of touting that a little bit, that this is a much larger increase. Not really shocking, right? And it goes on to talk about the different stocks that have already rebounded. You got United Health Group, Elevance, Humana, InsurTechs like Clover, CVS, Alignment Healthcare. They're also seeing major stock jumps as this news has been released. So that's all I'm going to say about that, because there's not much else to say, really. But basically, Medicare Advantage plans are getting a raise. We will probably see another massive footprint explosion this year. Wouldn't surprise me at all. And we may even see some increases in benefits. One of the things they were talking about at Medicarians, their speculation, because they weren't sure, are we going to get a big increase to MA plans? Or are we going to get a reduction? Like, what are they going to do? They didn't know. But one of the common speculations is that we would see more disruption again this AEP like we did last year. A lot of service area reductions, probably see bigger gaps in co-payments and co-insurance for the beneficiary. I'm not sure if that statement holds water now. Maybe we will, but with a 5% increase, I kind of doubt that. I think the plans will probably try to make themselves as competitive as they can while still maintaining profitability. I mean, we are definitely in a bit of a correction space right now in the Medicare Advantage world where it's kind of dialing back. But this increase changes a lot. So stay tuned. We will keep you updated as much as I can as this gets closer and closer. Obviously, we won't see a lot from new plans until we get, closer to October. We'll get some ideas. But it kind of makes me wonder, I wonder if Devoted somehow had a heads up or maybe knew that this was a good chance, because Devoted announced about a month ago, maybe not even a month ago, that they were going into, I want to say it was 9 more states. Maybe it was only like 6, but they've already announced they're expanding into several new states for next year. So we know that we're going to see footprint expansion from Devoted. We're probably going to see it from a lot of other carriers. So, if you are an agent in the Medicare space, that should be music to your ears, because that is going to increase the amount of sunshine you have to go out and make hay. Now, with all that said, I want to go through the CMS final rule. On Friday, this was dropped. Last Friday, they dropped the new CMS final rule for 2026 with Mr. RFK Jr.'s signature on the bottom of it. You may have seen it right here. Let me share this. I'll just show it to you. I'm not going to plug this whole thing. I think it's like 430 pages or something like that. But you can pull this up. I will make sure this is linked in the group for you that you can check out. But right there is the Big Daddy himself. It's 438 pages. You can check it all the way down. This goes into effect January. This is for plan effective dates, January 1, 2026. Right? There's Big Daddy's signature right at the bottom, RFK. Before I dive into what they included in this rule, I actually want to talk about what the original proposal was first. So bear with me a second to pull this up. I just want to get this back to the top for you. I'll make sure this whole document's in the group. So if you want to peruse all 438 pages of it, like I've been doing, you can certainly do that. But originally, they had some other ideas. I'm going to pull these up real quick. I have them bullet pointed for you. Right here. So this was the proposed changes that they wanted to make for 2026. I'm not sure how well you guys can read those, but number one was cost-free vaccines. Number two was affordable insulin. They wanted to maintain the $35 insulin cap under Part D and B. They wanted some easier drug payments, right? So they wanted to push further the Medicare payment program. Obesity medications, which I just talked about, right? They were trying to get obesity medications covered for the final rule 2026. They wanted to enhance fairness through health equity. They wanted improved integration and care coordination for dual eligible plans. And then here's the three that I think agents were most concerned about. One, promoting informed choice, right? Format provider directives for Medicare Plan Finder. That one would have been, I was actually really excited about that one because not only, at least my understanding, if they could create a standardized platform for Medicare plan directories, their main focus to doing that was for the Medicare.gov Plan Finder tool. But I was excited about that because I thought that would filter down to platforms like Sunfire, like Connecture, like Ascend, whatever, where they would have a much more accurate database to verify what doctors are in network, et cetera, et cetera, et cetera. So that one was in the original proposed rule. And then the other two, these are the two that agents were a little most concerned about, actually. Promoting informed choice, expanding the agent and broker requirements regarding Medicare Savings Program, where you had to go through a specific checklist to make sure that you talked about all of those programs, right? That a Medicare supplement or a Medicare Advantage plan is not Medicare supplement insurance. You had to explain Medicare Savings Program to them, even if they were maybe an IRMA person, all of that. And then finally, enhanced review of marketing. And this was the one that I think agents were really concerned about because they were going to expand the definition of marketing that it could likely apply to your websites, your just an educational video that you throw up just talking about Part B, but not actually talking about plans and benefits. Like they were looking at expanding the definition of marketing in a very, very large way. So those are the 9 items that were on the proposed rule. But I'm going to talk about the items that were actually passed. So I don't have anything to share on that with you. So you're just going to have to listen for a minute. So bear with me and let me get my notes open for you guys. But here are all the items that they asked for. 5 primary items, right? So on the original proposed rule, we had like 9. They finalized 5. Number 1, free vaccines, still on the block. Number 2, cheaper insulin, still on the block. Payment plan for medicines, the 12-month payment program, still on the block, although they have updated it quite a bit. Number 4, better support for special needs. So that one, again, was in the proposed rule. They're pushing that forward with some upgrades. And then 5, quality checks, primarily when it comes to codifying and so forth. So those are the 5 main categories, right? So free vaccines is pretty much just carried right over, right? No deductible for Part B, Part D, all your vaccines, right? Flu shots, COVID, shingles, etc., all zero cost. They just carried that right through from the Inflation Reduction Act. No real changes there. Same thing on the insulin. No real changes there, right? $35 insulin. But you'll actually, and I believe this was exactly as the previous rule was written. I don't think they updated this. But basically there's 3 options. You're either going to pay the lowest of one of these 3, $35, or if 25% of the maximum fair price that the government negotiates, if that's less than $35, you would pay that. Or if 25% of the plan's own discounted price is less than $35, you would pay that. But regardless, if it's on formulary, the most you will ever pay for insulin is $35. No changes there. Pretty simple. Next thing they threw in, they updated a little bit on the Medicare payment program, right? So this was introduced last year for the first time, where you can now spread out your Part D drug cost across 12 months. in case you're paying a lot of money on them. So obviously they're keeping that, but they've updated a little bit. Let me go through those updates for you. Bear with me just a moment to find my little notes here for that. I've got a lot of notes and I'm just having to kind of run through them all. That was higher. And most of what they changed was reporting requirements, right? For example, they came up with a system for in the event that the beneficiary doesn't pay their bill, right? Because under the 12-month payment program, basically the carrier is going to cover those costs, and then they're going to bill the beneficiary every month the same rate so that they can spread it out and make it more manageable. So they came up with an idea that, hey, what happens if that person does not pay their balance? So they figured out some ideas on that. So going through this, let me tell you exactly what they've updated here. So they added in, number one, some new communication rules from the carrier, right? They want to improve timing of annual notices, certain enrollment kits, explanation of benefits, and any outreach materials. All of those items have to include info on the Medicare payment program, right? They want very specific notices on how they're doing that and certain timely notices. So you'll see some stuff there. Website requirements. This is an agent. This is Medicare website and carrier websites, I should say. Medicare drug plans must include easy to find information about the payment plan on their website. And that includes eligibility, enrollment procedures, frequently asked questions, and monthly billing details. So they want all of that to be included. I say it's number 4 because it's in my subpoints here, but this is still under the Medicare payment program. They want integration into the LINet program. So that's for people with low income subsidies. So it says LINet's a temporary Medicare drug program for people who are newly eligible for low income subsidies, but not enrolled in Part D. CMS is waiving the payment plan requirement for those people because that is a transitional short term. They're not meant to be sitting in that program for a long period of time. So the 12-month payment program doesn't really apply. So they're nixing that part of it. And then how are they going to take care of unpaid balances when it comes to the Medicare payment program for drugs? Well, using their MLR ratio calculations, right? They're going to come up with some new coding. Here's what it is. Where did it go? It's going to create a new safety net, basically, right? So these people are able to spread their stuff. So here it goes. Here we go. Boom. Starting in 2026, what happens if someone doesn't pay all their monthly payments? Perhaps they disenrolled from the plan mid-year, or they just quit paying the bill. Either way, right? What is going to happen with that unpaid balance? Well, they're going to use the numerator in the medical loss ratio, right? That money is money that's spent on quality care or spent on care and quality. So CMS is saying that if a person doesn't pay their monthly payment, that amount shouldn't count as though the plan was spending it on care, right? Because the plan didn't actually receive the money, so it shouldn't be treated like an expense that benefited the member. The denominator in the MLR ratio, that's the total premium revenue that they collect. So if a payment wasn't made, CMS is clarifying that the plan doesn't have to include it as revenue. And that way they won't get penalized, so it won't look like that they're spending less on care making their MLR look like it's too low. So fairly simple there. They also want some accounting clarity, right? CMS wants to treat unpaid balances as uncollected cost sharing amounts and basically just handle them like bad debt. So the plans have to track and report those amounts clearly back to CMS, and they have to ensure that proper documentation for any amounts that are not collected. That starts 2026 and beyond, right? Fairly simple. Next one, I want to go through with you is on, because man, they've got a few things here. Next one is on better care for Medicare and Medicaid. So they're making some upgrades on that whole integration. Let me get to my expanded notes here for that real quick. This is a giant scroll, that plan. That thing is so big. No. Hang tight. I know it's in here. Here we go. So better care. So a couple things that they want there. Number one, they want to standardize some of the communication for dual eligible beneficiaries. They want to make sure that the information that's being sent to them within enrollment guides, plan materials, explanation of benefits, evidence of coverage, all of that stuff, they want to dumb down some of the language. They're tired of seeing all the legal jargon in there, and they want it to be delivered in plain language that anybody should be able to understand, so they really understand what their benefits are, right? And they want to have some separation in designated contact points for Medicare, for Medicaid, pharmacy benefit services, etc. They want to create a lot more clear communication to the beneficiary and all the different plan materials. That's one of them. Number two, better integration for Medicare, Medicaid services, right? So they are encouraging, requiring more. They're pushing for more integrated special needs plans. And those are obviously plans that are better coordinate between Medicare and Medicaid. They share data and they ensure that there's one point of contact. So that trend didn't change, right? They started pushing this a couple of years ago. That's already in the Inflation Reduction Act and the plan, right? Where we're going to see everything. We're going to see the number of D-SNP plans probably start to shrink as they want to push for people being in an integrated plans. So they're keeping that in there and they're really pushing for it. They are boosting requirements for personalized care plans, case management, and transition support for like when somebody leaves the hospital. Plans must work with your enrollees' families, community providers, Medicaid caseworkers. They want better assistance and onboarding when it comes to their integrated care options. And they want better help from unbiased sources, such as state health insurance assistance programs. A few other things they are going to work on is they're adding more data that they want on the plans to report on how they're serving their beneficiaries, right? When it comes to access, health outcomes, and satisfaction. They're looking for an increased amount of data in those areas. But ultimately, in summary, basically, they're looking for the improved care coordination, reduce confusion through more plain language when you're looking at materials and so forth, and then enhanced communication. Star ratings are also getting recalculated. Check this out. They are making some fairly significant changes to. So as we know, star ratings got adjusted again in the last year or was the last 2 years? And it pissed off a lot of the carriers because they saw star ratings drop, which cost them bonus money. So we had Elevant sued them, I think Scan sued them, and I believe United Healthcare also sued them. And I believe all three of them won those lawsuits on the star ratings. So they come back and they're reformulating that, and they're adding some new stuff in. Check this out. CMS is introducing a dedicated quality measure tracking how often women in the eligible age range of 50 to 74 get breast cancer screenings. They're putting that in the star ratings. Plans will be scored based on the percentage of women who get screened within the recommended time frame. This measure is based on data from the Healthcare Effectiveness Data and Information Set. Why it matters? Well, because early detection saves lives. Pretty simple. So they are really pushing more preventative screening. And I had trouble verifying this 100%. I believe this also includes colorectal cancer screening. Same thing. But they specifically, when I went through here and pulled it out, they specifically went after breast screening and said, hey, we definitely want to get some reporting requirements and some track how often women are getting breast cancer screenings so that we can measure that data. And they also are changing the weighted scores of the different items within the Part D. And I'll go through that for you in a second. So CMS is adjusting how much certain measures count toward the overall star rating. Measures that reflect actual outcomes, like hospital readmission rates, patient improvement, will carry more weight. So I'll say that again. Measures that reflect actual health outcomes will carry more weight. Patient experience and access measures will be important, but slightly de-emphasized, right? Why did that matter? Well, plans won't just look good on paper. They have to actually improve health outcomes. And this has been the big trend that they're pushing for, which again is why they're going after preventative measures in there as well. So a couple of other things. What's changing? Some older or less meaningful measures are being retired, and they're adding new measures for health equity, preventive care, and chronic condition. Case mix adjustment. Plans will not be unfairly punished if they serve sicker or more complex populations. CMS is revising how score thresholds are set, making them less sensitive to year-to-year noise data, and they're adding up some guardrails to prevent big swings in star ratings that would technically really just be a small performance difference. Coming through some more. And again, this all goes into effect January 26th. So here is, I'm going to give you a little more detail on these star ratings. Number one, CMS recognizes that not all patients receive the same quality of care, especially those from marginalized or underserved communities. So they are. Number one, they're stratified reporting. Plans will be required to break down performance data by demographic group, such as race and ethnicity, dual eligible status, and their disability status. So this will identify disparities and hold plans accountable for addressing those items. Next, new health equity index coming soon, it says. CMS is developing an index score that will reflect how well a plan is serving low income and high risk populations. The future goal is that plans that perform well on equity measures may see this reflected in bonus payments and certainly star ratings. Preventive care measures. And again, we're still going through the calculation, the adjustments they're making to star ratings. Preventive care measures. I already mentioned this, breast cancer screening. That's a new measure they're adding. So it will track how many women aged 50 to 74 receive a mammogram in the last 27 months. And it will be tied to the U.S. Preventive Services Task Force recommendations. And it will be collected through that health equity distribution index I mentioned earlier. Yes, here it is. Colorectal screening. I can't say that right. Colorectal cancer screening. Updates existing measure reflect more accurate screening timeliness. Emphasizes the use of non-invasive screenings as well as colonoscopies. Immunization status, right? So measures for vaccination rates. So they want to know, like, what are the vaccination rate for the people that are on your plan, whether it's influenza, shingles, pneumonia, COVID, right? So ton of preventive stuff is getting put into the star ratings because if you can handle preventive care, right, less chronic problems. That's the whole idea there. But speaking of, we're still under star rating adjustments. CMS is reinforcing the importance of long-term consistent care for people with chronic diseases. They are going to update to better reflect blood control sugar thresholds from the diabetes care. They want to know what the percentage of diabetic members with poor control on their HbA1c with the goal of reducing that rate. Blood pressure control. They want to look at how well members are managing their hypertension, including monitoring and medication adherence. And will use electronic clinical data when possible. For example, like having a blood pressure cuff at your house that you can use and check yourself, whatever. Medication adherence measures, right? Refill and take medications for diabetes, hypertension. They want real-time pharmacy data that shows when these people are properly taking their meds to treat their chronic conditions. They're going to add in depression screening as a potential star ratings manager or measure, where people are being properly screened for depression and then referred to behavioral health. So kind of in summary for these star ratings, right? The goal is to help close gaps within health equity across racial and socioeconomic lines, hit hard on preventative disease measure. So if you have a plan that's really good at preventative measures, they're going to get some big star ratings and ultimately improve the care quality and health outcomes. That's the big stuff. Now, I mentioned they're changing also within the star ratings a new weighting strategy, right? So for example, the current weight for clinical outcomes is 3x. They're moving that up to 4x now. So they're really putting more emphasis on your health outcome through your whatever their situation might be. They are dropping patient experience and access. Currently weighted at 4x, they're going to drop it to 3x. Intermediate outcomes, A1Cs, blood pressure, that stays the same. Administrative measures, that stays the same. So all they're doing is they're increasing the weight of health outcomes on your star rating and decreasing patient satisfaction, right? So a star rating score will be less affected if someone is just unsatisfied with the plan, but it'll be better affected if that person's health outcome improves. Fairly simple. All right. We've got a couple more to go through. And then, I mean, if you heard what I said earlier, like the two big problems that were in that final rule, all the marketing stuff ain't in there at all. Completely out. Completely out. I got one more that I want to run through with you guys real quick. So let me scroll here. This is a giant document that I'm running through. Just hang tight with me for a second. Lots of coding stuff that they're doing. Multi-language support. They're pushing another push on that. Just want to make sure I'm in the right spot here real quick. It's nuts. They are continuing all of the drug price negotiations. No stops there. So, for example, the IRA allowed for Medicare to negotiate drug pricing. They are not stopping with that. They're going to keep going after it. What they do want to change is how those prices are applied properly at point of sale. So they're updating some requirements there to make sure that when that person is at the pharmacy, that the discounted rate is absolutely reflected at the point of sale. So that is good, because just getting a reduction on drugs is one thing, but making sure that it actually goes in. So here we go. Ensuring pharmacy level application of the maximum fair price. CMS requires that pharmacy claim systems and PBMs must be updated to recognize and apply the negotiated rates at the point of sale. And Part D plans must enforce this through contracts with their pharmacy networks and pharmacy benefit managers. That's the big one. Some data. They added some data and reconciliation requirements on these negotiations to help them. Manufacturers, plans, and pharmacies, they all have to report how their drugs are priced, dispensed, and billed. Any discrepancy in pricing, i.e. a drug that's not billed at the maximum fair price, must be reconciled and corrected. So they included some new rules for coding of MFP requirement or compliance, and plan must now report of negotiated price use. Fairly simple. And again, that goes into effect 2026. CMS is also giving itself, and this is still under that same price of drug negotiations, CMS is giving itself explicit authority to audit plan compliance when it comes to maximum fair price application, impose penalties for failure to comply, and require corrective actions. Pretty simple. Ultimately, what that means for beneficiaries is that we should have much more accurate negotiated prices that they're getting at point of sale, no confusion, and make sure that that gets passed through. Boom. Next one. ID card improvements. This is the last one, as a matter of fact. This is it. Like, this is all they're putting in there. When I first saw it and kind of looked at it, I'm like, this is almost kind of a little bit of a nothing burger. All they really did, like when you look at it, is they eliminated all of the ridiculous marketing stuff that was on the original proposed rule, things that we were all nervous about as agents that we thought were going to affect us. And then they went after them, the more direct things to beneficiaries and plans, hopefully in a goal to improve cost, improve efficiency, and ultimately increase health outcomes and equity. So they went after all that, and they didn't 86 any of the stuff that we know is good for beneficiaries. But they do want to make some additional improvements into Medicare Advantage and Part D ID cards. CMS is implementing specific new content and formatting requirements for plan-issued ID cards. They want to make them easier to read. They want them to be more useful in real life settings, such as a pharmacy or doctor's office, and more consistent. So what's going to be required on the new ID cards? Well, here is what is required. Must include a toll-free number and a TTY number for customer support. Has to be clearly labeled and easy to find. And it must also include separate numbers for medical services versus pharmacy benefit services. It also must include the plan's name and address for submitting medical claims, and of course, their electronic billing identifier or payer ID. It has to have a minimum font size. It must use plain language, and it must use a high contrast color scheme for better visibility. If you were dual eligible, it must include their Medicaid status, and it must include contact info for that state's Medicaid offices or coordination services. Additionally, they are adding in standardized terminology that will be consistent and standardized terms for all written materials. A lot of that already is, but they're pushing it a little further to be included on across everybody's annual notice of change, everybody's summary of benefits, everybody's evidence of coverage. They want to standardize a lot more of the terminology to prevent confusion. And again, they want to get a little bit away from technical language, legal jargon, and make it more in layman's terms, right? Because let's think, I mean, your beneficiaries, they're not insurance agents. Not all of them, at least some of them probably are. They're not lawyers. Certainly not all of them. Some of them might be. So in reading some of this material, like that's why they need us. That's a big reason why they need us. But ultimately, I agree. Like we need to make it very simple for them to read this stuff and understand it on their own so they know actually better how to use their plan, right? So they want more multilingual support. As a guy that runs a Spanish language group, I'm super excited about that one. And again, plain language. So they have to provide materials in multiple languages, and they must write at a 6th grade reading level or lower when possible. 6th grade reading level or lower. That'd probably be good for a lot of the agents out there too, to be honest with you. Why it matters? Well, pretty simple. It's going to help beneficiaries use their coverage more easily, makes ID cards more functional, improves provider billing accuracy, and again, promotes health, equity, and access. That is pretty much it, man. There is some new codifying guidance as well. So I'll go through a few of those with you. This is nothing, it's a lot of the same stuff, but I'll run through this with you as well. And it's basically when it comes to marketing and communication regulations. Yes. Plans, CMS is codifying prior guidance related to marketing practices. Here we go. Required pre-enrollment information. Plans must give accurate, standardized benefit info before enrollment. Pretty simple, right? You got to provide them. There's no change here. You got to provide them the drug formulary, summary of benefits, provider directories. Nothing changes there. Prohibited marketing practices. Again, no changes. Cold calling without permission. We already know we can't do that. Misleading plan comparisons. Can't do that anyway. Coercive tactics. Explicitly banned in the regulation. TPMOs will face stricter compliance standards, is what it says, and plans that violate those can face formal penalties. Agent, broker compensation and oversight. CMS is setting permanent rules to cap broker commissions, ban steering incentives, and require clear disclosure for agent affiliations. It's really nothing. Honestly, we weren't supposed to do that anyway. So there are some, I'm kind of curious. It doesn't say much on the steering incentives, but they don't have any rules in here yet. This is just stuff that they're looking at. So we may see some more things come down the road to update this. But that was a couple of add-ons they said for codifying, was that they are looking to standardize a lot of the practices, require pre-enrollment info, which they already saw, and then they reinforced prohibited marketing practices, which is primarily cold calling and misleading plan comparisons, which you can't do anyway. Standardized notices, they are updating some time frames, nothing big there for notifications in that. And when I'm talking about notifications, I'm talking about the carrier sending notifications to their client, and that's in regards to like the supplemental benefits, appeals, grievances, all of those things. They want better plain language format on those, and they want certain time frames. They did not outline the time frames that I could find. So we may see some of that later. And that is pretty much it. That is pretty much it. So if you're an agent and you're looking at this new final rule and you're thinking about, well, shit, they also just increased Medicare Advantage payment benchmarks, probably going to be a really good year next year for us in the Medicare Advantage world. Like everything, all signs are pointing to yes. So like coming off of Medicarians, listening to all those executives and very high level people express their positive bullishness about the Medicare space, seeing the CMS proposed rule or final rule that was dropped last Friday, and then now seeing the benchmark payment for Medicare Advantage going up again and going up at a large rate. The future looks bright, my friends. The future definitely looks bright. So get excited, man. Get yourself ready. Finish out 2025 strong. I will keep you guys updated when I see some new things, because I'm sure there's going to be some additional details or expansions on some of these rules that they said, hey, we're still kind of working on this, like that health equity index. They said coming soon. Some of those details, I'll update you guys when I see them come in. So keep your eyes peeled. Drop your questions in the comments, and I will post some of this in the group for you guys as well. But until then, have yourselves an awesome Tuesday, and we'll see you next week for Tuesday training.